As far as an outline, we'll first go over the clinical case. We'll then talk about novel diagnostics and interventions, followed by challenges and considerations in this case.
And we'll start this presentation with maternal and perinatal history. So this patient was born to a 32-year-old G2P1 to P2 mother with maternal past medical history of type 2 diabetes, cardiomyopathy with reduced ejection fraction. She did receive good prenatal care with relevant prenatal studies as written. Her pregnancy was complicated by superimposed preeclampsia with severe features, fetal aqueductal stenosis with severe bilateral ventriculomegaly. The patient was subsequently enrolled in the North American Fetal Therapy Network prenatal diagnosis of aqueductal stenosis research study, which included an MCA Doppler screening to assess for elevated intracranial pressure. Based on this screening, fetal anemia was identified, and the patient required chordocentesis for PRBC transfusion.
As far as the birth and initial ICU course, the patient was born at nearly 34 weeks via cesarean section for ventriculomegaly. He received antenatal steroids. He did require neonatal resuscitation, and initial chest x-ray was consistent with respiratory distress syndrome.
And on initial examinations of this patient and through his initial evaluation, several abnormalities were noted. So this patient did have septo-optic dysplasia as well as hydrocephalus and macrocephaly. Other abnormal facies including posterior rotated ears, hypertelorism, as well as hypoplastic right 4 through 6 ribs, T7 butterfly vertebrae, hypoplastic T8 vertebrae, short bilateral humeri, filar lipoma, and tethered cord. This patient was also found to have thymic aplasia, defects in cellular and humoral immunity, hypoparathyroidism, hypocalcemia, as well as an ASD and VSD.
So based off of the initial presentation and the different abnormalities he had, is there a differential diagnosis you guys have? Are there certain test recommendations you would have at this time?
Initial differential diagnosis included FOXN1 deficiency, 22q112 deletion, charge syndrome, as well as complete DeGeorge syndrome.
As far as test results, the initial lab studies we received included newborn skid screen, a TREC count, a CBC with differential, lymphocyte subsets, recent thymic immigrants, quantitative immunoglobulins with an IgE, a memory B cell panel, a mitogen proliferation study, and a TCRV beta repertoire study.
Initial newborn screen collected on day of life 1 showed a skid screen that was inconclusive. Another newborn screen collected on day of life 26 also showed an inconclusive skid screen. Newborn screen collected on day of life 30 returned as presumptive positive skid screen, and on communication with PerkinElmer, the TREC count was 0 for this patient.
As far as pertinent lab findings, so he had lymphopenia. Lymphocyte subsets were notable for a low total T cell count, low CD4 and low CD8 cells. However, B cells and NK cells were normal. Recent thymic emigrants were low. Immunoglobulins, IgE, IgA, and IgM were normal, whereas the IgE level was elevated to 4,200.
Looking at some functional studies as well. There was a mitogen proliferation study that showed significantly decreased CD5 positive total lymphocyte and CD3 positive T cell proliferation responses to PHA, as well as marginally decreased total lymphocyte and normal CD3 positive T cell, significantly decreased CD19 positive B cell responses to pokeweed mitogen. In terms of the memory B cell panel, there's a decreased absolute number of B cells with absent class switch memory B cells, increased population of transitional B cells that was overall indicative of humoral deficiency.
As far as the TCRV beta repertoire, there was increased representation of TCRV beta families 5.1, 7.1, and 21.3, with concomitant decreases in other TCRV beta families, indicative of oligoclonality. Does anybody have a diagnosis that they would like to share as to what they think the patient has? So the way we thought about this case, so we know that there was low T cells, but B cells and NK cells were positive. So that put us in this bucket of either specific SCID genes that can cause this lymphocyte phenotype versus thymic defects like DeGeorge syndrome, Chard syndrome, FOX1N1, PAX1, TBX1.
And in terms of genetic testing, this patient did have a normal karyotype and SNP microarray. This patient also had a hypoparathyroid gene specific panel that was overall unrevealing. Clinical exome sequence analysis did reveal some variants of uncertain significance of the likely pathogenic variant in CR2 that is associated with autosomal recessive CVID, likely pathogenic variant in RFX7 associated with autosomal dominant intellectual disability, and VUS and SCN8A associated with autosomal dominant epileptic encephalopathy, none of which quite fit this patient's clinical picture, which prompted us to do more.
So as far as working through the diagnosis, so the positive newborn screen was positive, so then that brings you to flow cytometry, and like I mentioned earlier, we had the T minus B positive NK cell positive phenotype, so that's possibly congenital athymia. Genetic evaluation would give you more conclusive finding. However, in this pathway, syndromic comorbidities suggest that it is more likely that you're going to have congenital athymia. As far as the different types of genetic evaluation, so you can always do a genetic panel for SCID, and if the SCID genes are identified, that's a confirmed diagnosis for SCID. If there's no genes identified, you would then proceed with whole exome or genome sequencing. Similarly, if you did a chromosomal microarray and you found the 22q 11.2 deletion, again, you would get the congenital athymia diagnosis, but without it, you would proceed to whole exome and whole genome sequencing. And that's exactly what we did. And as Nicole mentioned, we didn't find any genes that suggested one way or the other. So with this published pathway, the next thing you would want to do is the artificial thymic organoid system to help elucidate whether this is SCID or if this is a congenital athymia diagnosis.
That's right. So we're at this point where we have a patient with a clinical picture that looks much like SCID, but with no noted genetic correlate, brings us to this artificial thymic organoid system. Dr. Haddad and authors reason that hematopoietic stem cells from patients who harbor mutations that can impact their differentiation into T cells, they should not be able to produce those advanced T cell precursors, even in the presence of an artificial thymic organoid. So in patients who are only affected in their thymic function, such as in the DiGeorge syndrome or in TBX1, they should be able to properly differentiate into CD3 positive T cells in the presence of an artificial thymic organoid. I'll direct your attention to the flow shown in the right-sided figure, where B represents kind of a patient with RAG1 hypomorphism presenting with Ullmann syndrome. And as you can see, like they can differentiate into that CD4 positive, CD8 positive, double positive stage, but not able to show evidence of that CD3 positive cell presence, as compared to a patient like in A, who in the presence of an artificial thymic organoid, they're able to not only produce those precursors, but then also your more double positive and CD3 positive cells after culture with this cultured thymic tissue.
As far as other non-genetic causes of hypoplasia of the thymus or aplasia, things to note include diabetic embryopathy. The underlying mechanism is not completely understood, but studies suggest that hyperglycemia acts as a teratogen. Retinoic acid embryopathy, we know that isotretinoin is a known teratogen that represses TBX1 expression. It's associated with a wide spectrum of birth defects involving craniofacial and cardiac malformations, as well as defects in thymic development, including congenital athymia. And then lastly, maternal alcohol consumption. Studies in murine models have shown that ethanol exposure negatively affects thymic development.
Congenital athymia is an ultra rare disease with prevalence less than 1 in 50,000 people, characterized by immunodeficiency due to absence of a functional thymus. As we know, the thymus is the organ where T cell precursors mature and are selected to become naive T cells. In its absence, you can see profound T cell deficiency, frequent infections, susceptibility to opportunistic infection, as well as propensity to develop autologous GVHD.
As far as GVHD, early in this patient's clinical course, he developed signs and symptoms concerning for acute GVHD, including significant diarrhea with negative infectious studies, elevated fecal calprotectin indicative of enteritis, diffuse papular rash, hypereosinophilia with an absolute eosinophil count of greater than 5,000, an elevated IgE also greater than 5,000. On our differential, we thought about drug eruption in the setting of recent antibiotics, stress, viral exanthem, diaper dermatitis leading to eczema, but ultimately our highest suspicion was for GVHD.
And in terms of management of GVHD, systemic glucocorticoids have a place for patients with grade greater than or equal to 2 of acute GVHD or more. Elatemzumab is a humanized CD52-directed monoclonal antibody that induces profound and durable lymphopenia. Cyclosporin, used as an acute GVHD prophylaxis, is a calcineurin inhibitor. Acetylcholine P450 inhibitor, as well as a P-glycoprotein inhibitor that inhibits the synthesis of interleukins, including IL-2, which is needed for the self-activation of T lymphocytes and their differentiation.
As far as the GVHD, the next step was to determine, was this maternal engraftment versus autologous engraftment? And we were able to do HLA typing, and it was consistent with autologous GVHD. So we have a figure here, basically, that kind of spells out that in the setting of a compromised thymic function, there's activation of autoreactive T cells as opposed to activation of alloreactive T cells. And so we were able to diagnose that he had autologous GVHD.
In terms of congenital athymia management, really a big part is minimizing infectious exposures via protective isolation measures, which is like limiting visitors, protective pressure rooms, irradiated and leuko-reduced blood products whenever necessary, antimicrobial prophylaxis, including fluconazole, Bactrim, acyclovir, azithromycin, avoiding live vaccine due to risk of T-cell activation and monoclonal expansion, resulting in autologous GVHD, immunoglobulin replacement therapy, but ultimately treatment is cultured thymus tissue. And it's important to note that without treatment, congenital athymia is fatal, with nearly all patients dying within the first 2 to 3 years of life.
As far as treatment for congenital athymia, Rethymic was approved in 2021 for pediatric patients with congenital athymia. The Rethymic is not indicated for treatment of patients with SCID. So what they do is they administer cultured thymus tissue. So after administration of cultured thymus tissue, the recipient's bone marrow or progenitor cells migrate to the cultured thymus tissue to develop into immunocompetent naive T cells. The naive T cells then appear in circulation approximately 6 to 12 months after treatment and increase through year 2. Common adverse reactions include hypotension, cytokine release syndrome, rash, hypomagnesium, renal impairment, thrombocytopenia, and GVHD.
And this figure is sourced from the Duke Congenital Athymia Handbook, really summarizing some of the important um, points of monitoring as well as clinical management for these patients. So things like breastfeeding and vaccinations must be immediately stopped on a receipt of this positive newborn screen and during the time of their congenital athymia diagnosis. Protective isolation is recommended throughout the process from positive newborn screen through T-cell reconstitution. Infection prophylaxis medication is also recommended throughout this course as well. Immunoglobulin replacement therapy also recommended throughout this course from time of congenital athymia diagnosis through T-cell reconstitution. Lymphocyte count should be checked about every 6 months up until treatment with this cultured thymic tissue transplant. And then that's first every 6 months and then followed by every 3 months after that CTT treatment. Again, monitoring for signs of autologous GVHD. That's occurring from the time of diagnosis, but also very closely around the time of that initial implantation with the cultured thymic tissue, really just to monitor for signs of GVHD during that time. Regular pathogen screening is also recommended, monitoring for HHV6, HSV, CMV, EBD, adenovirus, and then continuing infection prophylaxis, Bactrim, azithromycin, fluconazole as well.
As far as the patient, so he suffered a severe clinical setback. As part of the screening for pathogens, his adenovirus PCR came back positive in January, and he had mild respiratory symptoms. He underwent a 9-week cidofovir course with no significant improvement in his viremia. Persistent adenoviremia threatens eligibility for a thymic implant as there is a significant morbidity and mortality risk associated with the required immunosuppression. And here you can see the adenovirus log copies, and they remained elevated for several months from January through April.
And at this point, just considering his adenoviremia and in consideration of his cultured thymic implant, there's discussion about virus-specific T-cell therapy. And from what we know of virus-specific T-cell therapy, it's been around for over 20 years. It has been used in the setting of hematopoietic stem cell transplant for malignant and non-malignant conditions. Current methods of a viral-specific T cell therapy production, they use either specific antigen, specific T cells using the MHC complex, or cytokine capture technology. There are also ex vivo methods that involve expansion of those cells with antigen stimulation. In this case, donor cells were collected via apheresis. Peripheral blood and mononuclear cells were loaded onto a magnetic cell separation device, and they were stimulated by viral-specific antigen, where the virus-specific T cells were collected and then infused into the patient.
New catch 22. So the patient was noted to have acute worsening of respiratory status, prompting multiple pediatric ICU visits, along with new onset maculopapular rash, plus or minus increased stool output. So with the discontinuation of cyclosporin in the setting of adenovirus, approximately 6 months since receiving Campath, recent VST therapy, and significant increase in total CD3 cells, there was concern for reconstitution of autoreactive T cells, leading to an autoreactive enteritis/dermatitis versus GVHD due to donor engrafted T cells. Ultimately, chimerism studies showed that the cells were 100% self. And then this is just a picture of the rash that he had during this clinical worsening.
At this point, we were faced with an additional clinical conundrum. Thinking about, should we immunosuppress with concern for this autoreactivity, given the significant risk of morbidity and mortality with active adenoviremia, or do we go forward with immunosuppression and risk the progression of this suspected autoreactivity? Ultimately, this patient was deemed ineligible for rethymic, the cultured thymic tissue, just due to this persistent adenoviremia. And eventually, this patient did pass away on home hospice in January of this year.
And so to wrap up, so a case summary and some learning points for you all. So we went over the workup of congenital athymia, including the use of the artificial thymic organoid system when genetic testing is non-diagnostic. We talked about some complications of congenital athymia, including GVHD, and we talked about rethymic as a therapy for congenital athymia.
And really, the take-home points are that congenital athymia is an ultra-rare and fatal disease without thymic transplantation. Timely workup of congenital athymia can guide critical early interventions. GVHD can rise even in the absence of allogeneic transplant through autologous T cell activation. And rethymic, this cultured thymic tissue is a breakthrough therapy, but access is limited by clinical stability and infection status.
Thank you all for listening.
Thank you. At this time, if there are any questions, feel free to unmute yourself or use the chat box. Y'all go ahead. I see you raise your hand.
Thank you. Great presentation. Very interesting and very challenging case, which I think the team managed way beyond what most other centers would have been able to. So kudos to you and the whole team. Just wanted to mention that you initially indicated that this could be graft versus host disease, and you continued on to use the term. I think it might be misleading. Some people call this omen, mostly because there was no external graft that caused the initial clonal expansion, the T cells. So just, not to confuse, it wasn't graft versus host disease. It was what autologous T cells expansion or omen or whatever you want to call it. So but otherwise, great presentation.
Thank you. Yeah, I think it really kind of drives home the point too of like the things that like we were thinking about in like our differential with this, patient first presenting with this skid-like picture and then with this like rash and eosinophilia. Then I think we like most commonly think of things like Omen syndrome. And then yeah, after we did that HLA like typing and then seeing that this was 100% autologous, and yeah, it kind of moved that description more towards this like autologous auto reactivity kind of picture. But yeah, thank you.
Thanks for that comment too. My video's not working. I don't know. We tried, there were a lot of social complications with this case as well. We tried for another round of uh the the VSTs, but the donor was had some issues, including a was it did he get like a fellows remind me, I think he had a restraining order, so he's no longer allowed to come to the hospital to donate
Yeah.
again. Yes. So
Yeah.
there
That is
were
true. Yes.
yeah, so there were a lot of social complications that made the case really difficult. And ultimately, because of this serious challenge of the balance between the adeno and the autologous GVHD, after a lot of meetings and with supportive care, the family decided to just take him home, and we kept him on Prophy and IVIG, but ID felt that there was no more utility in trying to treat that, knowing that everything had been done that possibly could be done. And so he passed away, but it was at home with his parents. So that's the sad, tragic case of it, but he was not, they would not allow him to stay on the transplant list with his adeno.
Say it again. The clinical care, way more than what he would have received the patient would have received in many other places. So kudos to the team and working with the family and with all of this.
Thank you. I think the good thing after that, though, is we had a CHD7 who came to us from UAE that we recognized and got them on the transplant list and had them. They actually, when they realized the insurance, just even to get rethymic, the process of having insurance coverage can take a year. So if you look, if the CS just had two abstracts from the rethymic folks at Duke, and if you look at the time between referral and the time to transplant, it is, so I think I wrote down that the time, the day of life average of the 63 patients who had been transplanted through Rethymic from 2018 to 2022 was on day of life 965 was their average day of life to get transplant. So there is so much delay in having a diagnosis, letting them know about the diagnosis, and then getting insurance to move to cover the services. It really is seems to be a big problem for them. But our other patient, when we had them diagnosed shortly after this patient, to get around to, they actually moved. They literally displaced themselves, left, and moved to North Carolina to get on Medicaid there to try to speed up the process. But they are still not transplanted, but they are healthier and doing well. So, but yeah, I was really, I was really surprised to see how long it takes. So let's see. I think there's a question here. Yes, it is available both. It is available commercially, but also available commercially only at Duke. So they're both true. And it used to be available only at Duke through not commercially, but now it is the company that owns Rethymic. Um, so I don't know their plans for disseminating this.
So this is Holly Miller from Phoenix Children's. I know that they submitted to the FDA um, uh, a few institutions nationally for harvesting of thymic tissues. Because one of the limitations for rethymic has been getting appropriate tissue at Duke, because you have to culture it from an under 9-month-old, and it has to be certain size. And the older the kids are, the bigger the thymic tissue that's required for them, because it's all weight-based. And so that's kind of their current steps to expand availability. And then on the back end, they are attempting to expand the institutions nationally while keeping it limited, because there's typically only about 10 to 15 of these infants born annually in the United States.
Right. Thank you. Has anyone here ever done transplant for this? Because I know that has been discussed for many years, just doing a bridge transplant because obviously that's not curative, right? So if anyone has experience.
Again, I have not personally, but I had managed a couple of patients who previously had transplants, and their immune reconstitution is just horrendous. So, because their marrow already makes T cells, it's just they're not getting the further education in the thymic tissue. And when you transplant them, they basically have like increased autoimmunity because their T cells aren't learning in the appropriate manner, because there's not a thymus to teach them how to mature. So it's not great, which is why we don't transplant them.
Yeah, that's how I felt too, that the data wasn't very solid. I know people do it as a Hail Mary when they know that the thymic transplant is not going to be an option, or may not be an option for years. But it's really surprising if you look at the registries, because I was looking before this of how many of them get this autologous GVHD. So it looks like in one of the abstracts that 70% of these congenital thymic patients presented with autologous GVHD. I mean, that really just complicates things. And I think the one other teaching point I just want to say before the end is that if you also look at their abstract at the CAS, that 24% did not have a genetic diagnosis. And so I think that's really just important here to highlight as well, in that these athymic patients, they don't all need to have a precise genetic diagnosis. This is still something that you can have through gestational diabetes or just through syndromic features. So to not rule that out when you see someone with a recent thymic aggregate count of 0%, even if the genetic testing is negative, that this is still something they should really think about.
Having 2 patients recently with absent T cells and negative genetic testing, I will say it's pretty difficult to tease out whether it is a thymic issue or a bone marrow issue, because you essentially have to send it to NIH, or Eli Haddad is now doing it again for select patients. And so it is time consuming to figure that out when they do not have a genetic diagnosis.
It really is. And Ali Haddad has been very generous to us in doing a lot of our testing for us in these rare cases.
We have a new message in the chat. What is the current range of immune suppression used to control autoimmunity when it occurs? It says we touched on calcineurin and Campath. My apologies if I mispronounced anything.
So I actually rely heavily on my BMT folks for the autologous GVHD. So I will leave this to any BMT people on here, because we literally did treat this like autologous GVHD that you would see in more common things other than athymia.
Ariel, did you have a comment? I see your hand
Yeah,
is raised.
we do see quite a lot of these autologous, Omin, GVHD, whatever name you're going to call them, although the name is important because of the etiology. We often, depending on the severity, if it's really severe, we use plain old steroids. But then cyclosporin, we've used sirolimus a few times very effectively. But tacrolimus, after steroids, tacrolimus and sirolimus, we usually save the Campath for the transplant itself.
It says, assuming someone is using Ruxo. We didn't use Ruxo on our patient, but I don't know if others in this group are using Ruxo for management of this.
Are there any other questions or discussion?
I actually would like some, could you educate us, y'all, on the hammer, and what do you think, when does it called autologous GVHD versus Omen?
Years of debate. I'm not sure how to actually distinguish. In our center, this would have been called Omin. Other, I don't think there's a. It, question is whether or not there's a thought. I actually don't know. For me, it's the same.
Yeah, I
Sorry about
struggle
that.
with that. Yeah, I struggle with those two.
Yeah, transplanters have really gotten a way of calling it autologous graft versus host disease because there's no graft. It's their own cells that are autologously undergoing oligoclonal proliferation with energy. And so I think that's why most transplanters now just call it Omen syndrome because there's not a graft. Now, maternal GVHD is a thing, and that's why it's important to determine, are they mom cells
Right.
versus
Oh,
baby?
yeah, yeah. Those are totally different.
Yeah.
But I guess sometimes me it's confusing because when we historically have called things omen, I expect to see like I had an omens patient who came in, they had no eyebrows, they had eosinophilia, so do you call it a omens no matter what? No matter what the clinical features, doesn't matter, still call omens. So I think that's where I think things get a little confusing in that, is this a clinical entity where you should be experiencing this set of symptoms, or all you have to do is have any sort of symptoms plus 100% self, and then it's omens. I think that's where it's hard for me to understand exactly which is right or wrong. But if we want to call everything omens, then I say today, starting now, everybody, we all have to start calling it omens if it's 100% self and you have any symptoms. I'm in full agreement with picking 1 and moving forward with it.
Yeah. I don't think this is the forum to decide, but I think conceptually, yeah. I don't think you need all, like other syndromes or clinical features, you don't need all the features. And I do think this patient had the colitis that you mentioned, and there was skin. I didn't see any liver, typical liver, but there was some skin, although not the most classical skin. There was clonal expansion, energy of T cells. Some use combination of cytokine storm to better define this. Most places don't have that, or at least didn't have that in the past, so I'm not sure how much that would be helpful. I think eventually, whether you call it Omen or you call it autologous GVHD, at this point, you're going to treat it the same, and both of them indicate a severe immune deficiency. So, you know, I'd focus on other things. Let's get this baby well, which you did. Well, which you tried as hard as you could.
I think that's all we have.
Great presentation. Thank you.
Thank you so much.
Thank you so much for presenting today, UPMC, for representing NICER today. We really appreciate it. And CME to claim is in the chat. The link's there in the activity code. Please reach out to me for any questions. And we'll hope to see everyone next month. Thank you so much for joining in today.
Thank you. Thanks, everyone.